Jesse, you want to come on up here? I'd like to introduce Jesse Seeger Walls is his name, and he's a representative from Tri-West Consultants. Where do we want him? Down there? Okay, why don't you just come right here? Maybe you can see the screens better that way.
Morning.
Welcome.
Morning.
Jesse drove up from St. Louis, and they're trying to help us with a number of things, especially with grants and crisis response and so on. You're up, sir.
Great.
This is the microphone right there.
Certainly.
Bottom right.
I do have some colleagues that are trying to call in. Are we able to
Our tech guys
have them join?
are working on it.
Okay, great. Well, in the meantime, okay. I've had the pleasure of meeting several of you. We're working with the county on a potential of a SAMHSA grant for the system of care for children and youth services in the area. And I've gotten to meet several of you through Chestnut Health Systems, which is really the foray for us connecting with you all. I've been a consultant with Tri-West Group for over 8 years. My background is in clinical social work. I'm still a practitioner with a very, very small caseload that I like to maintain to keep my clinical skills. But I went into public health. So I hold a PhD in public health and health outcomes research. Tri-West is a health and human services company that focuses on behavioral health services for children, youth, and adults. We've been around for over 25 years. We've been evaluating SAMHSA grants, federal grants. We work with state agencies. We work for foundations, all the way from program evaluation to policy and planning. We've done a tremendous amount of work in Texas with the Meadows Mental Health Policy Institute, where we were the operating body for a long time when that first started. And we work with Healthy Minds. It's a policy institute in Tulsa, Oklahoma. It's relatively new, and we're largely the operating body for providing all of the data analysis and policy consultations for them. I want to pause so I had an opportunity to introduce some of my colleagues if they're available. It's not just a one-man show there. There's 25 employees. I'm a principal consultant along with Sam Shore, Lisa Tamaka, and who I hope to be on the call today. But we also have a full data team. I'm the director of population health at Tri-West Group, and that means I have a small team of programmers and analysts that work behind the scenes for all our program evaluations and assessments. Okay. So I'm not able to see them on the screen, but I would like to pivot and let them introduce themselves.
Matt, are we connected to our GoToMeeting link? Yeah? Okay.
Yeah. I'm actually on here too, and it says I'm still waiting to get in.
Yeah.
Just to. So they might be in the same situation. Hmm. Okay. Great. Well, let's rely on him just to let me know when I can. But at this point, I'd like to share the PowerPoint slide deck virtually through the GoToMeeting. Is that possible? Oh, okay. So I should exit out of here. And they said, no.
We apologize
Oh,
for our
here we go.
technical difficulties. I think we're going to get it here soon.
Taylor, there you go. Okay, great. What's that?
Is there a phone number you can call them? Because they just haven't got.
Yeah.
All the time, so, okay.
Uh, it still says I need to have permission to share my screen.
See, I think it's trying to say, get permission to share their screen. Anybody else have any projects they want to share while we're waiting?
Great.
They're showing it around multiple times. So they try to make
Yeah.
multiple use the presenter. They said, which one is you?
Oh, I don't. There's two, three of me in here now. I'm gonna just close out
Okay.
and rejoin.
Go to meetings tricky.
Yeah. Okay.
Thank you all for your patience. We apologize, technical difficulty.
Yes, thank you very much. Thank you all for your patience. So one of the areas in which we've been focused over the most recent years is helping agencies and systems consider how to better improve their crisis systems. We went ahead and in that process developed a planning tool. So when this project got started with Chestnut, we said, you know, one of the things that the SAMHSA grant they were working on was focused on improving referral pathways, improving connections to crisis services. And when we presented the suite of support that we're used to providing, they said, you know, we want to do this in coordination with our county. There's already current efforts going on, and we don't want to be a maverick that's trying to do our own analyses or do something that's tangential from our community and members. So they invited us to make connections with Vanessa and the county, and we saw earlier iterations of the mental health action plan. And after reviewing that, we first thought it was just remarkable, all the work that you guys have already been doing and all the accomplishments. And we work with communities that are far behind the coordination and efforts that you guys have been doing over the years. And so we said, you know, here are an array of activities that we think both engender the spirit of what the federal SAMHSA grant was wanting to improve and how it intersects with what you guys have already been describing in your mental health action plan. And so I believe you've all seen a 1.5 pager that briefly describes what that array is. And now there are some underlying principles that guide our support for any community or agency that we work with. One, we're trying to help organizations help people better. But in addition to that, we are always focused on complementing local efforts and supporting local accomplishments. We recognize that you guys have been doing this a long time and are really experts in this area in your community. And so anything that we provide is ideally complementary and not something new or something foreign coming into your community. We also look to help build capacity not only of the organizations that we work with, in this case, BHCC as a group, but all the individual partners that are providing. So when we use a tool, we're very transparent about the methodologies that we're using. And in the future, you guys or individual partners should be able to take pieces and replicate it for yourselves. And so we don't look at ourselves as an Apple device or something that you have to re-up with us after so many years because it's obsolete. And so we just wanted to make it clear that we don't try to parasite with the people that we work with. So the array of services were analyzed service utilization and costs throughout the crisis system, identify key performance indicators, identify best practices, support 988 planning, help reconcile service region and jurisdiction for crisis care coordination, and identify key data points needed for real-time coordination. So this is a suite of areas that we've worked in before and are prepared to provide support. And so coming to this morning meeting, we thought, well, what's helpful? Well, we think we would like to suggest one that is particularly helpful and actually intersects with all the other ones. And you guys could do parts of the other ones on your own or in combination with our support. But having a better understanding of utilizing our planning tool to have a better understanding of what's happening now, and what adjustments can happen at different segments across your system. So our planning tool looks at I sometimes call them stations within the crisis flow in which someone can intersect with your services and your service array, and understanding both not only the volume but the disposition that's occurring there and the cost associated with that encounter. This analysis, this planning tool involves key informant interviews with people around this table and other people that you identify that are essential for understanding the community system. And we do a request for information of existing reports. We don't come in and we ask for you to do new analyses, but what do you already have in-house? Sometimes identifying data that you don't have is a finding in and of itself, and says, here's an area to improve data collection, or here's a pivotal area in which you could implement a key indicator that could help better inform the system overall. And then the resulting would be a snapshot of what's happening now and what small changes could impact, both impact as far as needed capacity in the community, and a cost overall to the system. My colleague Sam Shore has joined. He's another principal at TriWest, and Kelsey is an analyst and project manager for us. Sam and Kelsey, I'm going to pause here and allow you an opportunity to introduce yourselves. I've already given a brief introduction over TriWest and TriWest history.
Well, good morning. Sam Shore here. Can you hear me okay?
Yes.
Great. Sorry about it. I had some connection problems this morning getting on. So Sam Shore here, principal at TriWest. And one of the areas that I've been focused on for the last few years is the area of crisis services, community-based crisis services. So it's been really interesting getting to know what the work of this group has been over the years, and looking forward, to working with you in any way we can be helpful.
And my name is Kelsey Urrutia, and I'm a senior consultant at TriWest. And I've also spent the past few years working closely in our crisis work, and particularly our crisis planning tool.
Great, thank you both. And both Sam and Kelsey were primary authors in developing our planning tool. A couple people that aren't with us at the moment is Lisa Tamaka and Suki Martinez-Parham. They are our children's experts. And so oftentimes people come in and they're really just focused at adult services, adult crisis. They bring with them that lens. And so that's when we're working with you all, we would have both this eye on children and youth, transition age, adult service, crisis services and systems. So this is just a schematic of an example adult flow. This isn't reflective of your system. This is just for examples of every line you see in here. Our planning tool would be focused on identifying what available information can we glean from each of those connections about people moving through the system, what decision points are being made and tracked at each segment, and what are the overall costs of the system and at each of those touch points. And here again is the list of the other areas of potential. Identifying key performance indicators. Well, this area will be improved once we have an understanding of what information is already being collected, the reliability, the accuracy of that information. Then we can identify what key performance indicators are already being collected, not just volume, but response times, drop-off times, other indicators of adequacy of a crisis system. Sam, do you have anything else you want to comment on in regards to the value of doing a planning tool and how it may inform these other potential areas of support in the future?
Well, just a couple comments I'll make. One of those is that I think we're all aware at one level or another that there's a big rollout of the new three-digit crisis line 988. And that's what that's come to represent, and what's happening at a national level is there are a lot of resources being marshaled to put out there to build out crisis systems at the local level. So the feds are putting money to states. They've made money available locally. Um, the use of ARPA funds, they clearly state in there that mental health is a priority. So there's a real spotlight on this area. So I think there's a lot of opportunities to take advantage of right now. And by mapping things out and really understanding your system, then you can make pretty wise decisions about where your community is and what enhancements actually make sense to do for you, because it's not a one size fits all kind of system. It really is dependent upon the inpatient resources, the crisis alternatives you have, the ongoing services you have available. So anyway, so I think it's important to understand what you've got and then start putting metrics to it, and also begin to monetize what is it costing you to do it or not do it, just so that you go in with eyes wide open.
And I want to pause. Lisa, thank you for joining us. I've introduced you a little bit, but I wanted people to hear your voice who haven't heard your voice, and allow you opportunity to say hello.
Good morning. I'm Lisa Tamaka, and I'm also obviously with Tri-West Group. And I really have worked almost all of my career and all of my time at Tri-West really looking at the children and youth side of this. And so, as you know, kind of came in the middle of what Sam was talking about, but really thinking about as that 988 line opens up, it opens up to everyone, and ensuring that all of the resources and supports are available for both children, youth, young adults, families, and adults. And so that's why I'm at the table.
Great. Well, thank you for giving us, thank you for your patience as we got started this morning. We're available for any questions that you may have regarding how we could potentially support the mental health action plan.
How long do you think this process will take?
Once we get started, it's not uncommon for these to take 6 months, depending on the availability of people involved. We also certainly have our other projects. Sam, I'm not trying to speak for your availability. What do you think of a 6-month timeline to a year timeline for using the planning tool?
Yeah, I think it's really dependent upon where the community folks are at in terms of being ready to provide the data inputs to make it real. The better, we have ways of estimating costs and utilization based on other experience, but it's always better to take real data that's happening at the local level and plug that into the planning tool. So the kind of things that tend to take longer are sorting through data and getting it cleaned up so that it's usable. Also, people's availability just to meet and inform the process. Those are things that make a difference. So it's really an interplay. We have kind of chunked it out at 6 months, and that assumes that some of that is ready to go or could be ready to go pretty quick. We also understand in community work, sometimes it takes longer to get the right people involved in the right ways. So I would say anywhere from 6 months, beyond maybe 10, just depends on what the community, how fast you're ready to go.
Yeah. Sometimes when we get summarized aggregated reports, certainly desk reviews don't take as long as if someone offers, hey, we have a data set that we haven't cleaned, we have available, we just haven't used it. That's something that we can help with. And so things like that. And when Sam says cleaning the data, making sure all the variables are and data are properly put in each cell and things are properly counted, that can sometimes take longer. And just for data requests, if people are slow to respond, it only delays our ability to formulate it and synthesize what's available. Yeah, Susan.
I just want to make a comment. They're not here today, but PATH is now an agent of the state because they have the statewide contract 4988. So just there might be some limitations on some of that because now they aren't going to actually be able to do some of the data that I think we were looking at for the future and some of our recommendations in the update. So just kind of wanted to let you know on that.
Tell me a little bit about the process, and when I mean like that, so many of us will know. Will there be a team of people come in town? What exactly will they do? Is there something you need to work, how to set up?
We can. I'm the only one that lives here close by. Sam's in Michigan, Kelsey's in Texas, Lisa's in Texas, and so we want to limit the costs of the project, and so much of it can be done virtually. Certainly, I'm able to come here this morning and meet with people in person. But it's very routine. During COVID, we've been doing lots of our assessments and continuing our work by doing virtual key informant interviews. We do get sensitive data, we have ways of establishing secure connections to make sure that we can get that in our hands without violating any HIPAA conditions. Sonia.
I'm interested in how you would approach our hospitals that have all the HIPAA regulations and so on for data. So how has this worked in other places? We're missing our hospital representatives this morning, so
Yeah.
I'll speak for them.
Yeah. So in my experience working with hospitals, sometimes we have a liaison that helps get us connected to the right person, our data counterparts. And oftentimes they'll participate depending on their willingness to make aggregated reports. In that case, we just say, here's the measure. We want the number or the people served by this month or by this year. That is not going to be a violation of HIPAA.
Yeah.
In instances where they want to share client level data, we would have to establish a BAA. We prefer to avoid that.
Okay.
And build collaborative relationships with any hospital systems that would be involved so that they would provide some targeted aggregated reports opposed to getting client level data.
To the extent that you can provide examples of other hospital systems that you've done this would be probably useful.
Great.
To our two systems here.
I'm evaluating a sobering center right now, doing it, working with their data counterparts. But Sam, have you worked with hospitals that have participated in crisis system assessments?
Yes. So in one community here in Michigan, actually, we did a project. It's Kent County, Michigan. They have like 5 significant hospital systems in that community. It's kind of a major metropolitan area for the western part of Michigan. And so all of the hospitals were able to give us emergency department data. Again, it was de-identified. So it wasn't a big HIPAA issue because they didn't give us client identifying information, but they were able to show us the numbers that are hitting their emergency departments, which is why they wanted to be at the table, because that was problematic for them, because often they would end up boarding people who needed a place to go and they didn't have it. So they sat there and kind of clogged up their emergency department, and they weren't capable of giving them the kind of care they really needed. So they have an incentive to be part of the solution because they end up being a place people show up and they have to deal with them, whether or not they're getting reimbursed for doing that. So yes, we've done it with those hospital systems, and they were able to give us ED emergency department data.
And I would say the same for our work in Tulsa, Oklahoma on the children's side. We were able to get de-identified information on the number of emergency room encounters for children and youth for behavioral health need, and then de-identified data as to what was the outcome of that ED visit. Did they go to inpatient? Were they discharged to a were they discharged to a residential treatment or inpatient facility within the Tulsa area or within the surrounding Oklahoma area? So we could really look at kind of the route these children, youth, and their families were taking and the amount of time they were spending in the ED. And so all of that information was de-identified. And as Sam said, they were very, very willing to be at the table because of the required staffing for a youth with a behavioral health need was really challenging their emergency departments. They wanted a solution to this problem that met the needs of children, youth, and their families and didn't clog the ED.
Thanks, Lisa. I just forgot that I had helped you with that analysis.
So just to comment on that, the hospital systems here have already provided us with data, de-aggregated data, of course, or de-identified aggregated data, of course. So I'm sure that won't be a problem. My question is this, and so TriWest is providing this service to the county as a part of a contract for a grant with Chestnut.
Mhm.
How might that inform this process, or how might that be brought into this? Is that going to somehow impact the recommendations, or I'm just trying to, when you do any type of research, right, the first thing you always look for is conflict of interest or
Yeah.
how that might impact things.
Well, it's not research, just to make that clear. This is evaluation. And the spirit of these federal SAMHSA grants, which is the mechanism in which this concept was born out of, was based on the focus on direct services grants. These are direct. They want to see people get served. They want to see systems improve capacity. I haven't had any experience from Chestnut that they are wanting to have any control as far as overview. But are you referring more focus on the reporting requirements to the SAMHSA?
No, I was just thinking in terms of if I had obtained a grant, right, I would be hoping that the outcome of that grant would be helpful to my agency, right?
Oh, yeah.
And so I didn't know if there was something within the process that is more geared towards how some outcome for the system in general impacting Chestnut services or something.
We haven't received that message from Chestnut at all. We understand that crew, the stabilization unit has been impacted, but there's been no messaging that we want to focus on stable building capacity there or getting that back and up and running. And we want a report or something that's targeted that way. That once they pass this over to Vanessa, we've been working exclusively with Vanessa on, communicating what we think could be complementary and supportive.
Yeah, if I could speak to this a little bit, Matt Mollenhauer with Chestnut. Obviously as a piece of one of those circles on the slide, our hope, frankly, out of this is that the system improves, but I would hope from a Chestnut standpoint, we learn what we're doing wrong and get better at it. I mean, the reality is that in the end, it's the system across the county of which we're one component. And so in there, we have our own flaws and how that works. And I see that as part of the outcome, to be honest. I'll also make a secondary comment. I want to thank Jesse and his team. In the last 3 weeks, they have come back, not they as in TriWest, but they have come back and kicked the budget out as rejected more than once. And his team has been incredibly responsive and flexible and helping us address costs within the budget without changing scope of the project. So just Jesse acknowledging your team for that effort as well. Thank you.
We're committed to the people of McLean County, and the SAMHSA is going to do what SAMHSA is going to do. Federal government's going to do, but we believe in what you guys are all doing, and that's how we approach all the clients we work with. That we have been clinicians in our past lives. I still practice, and we have, even though we're a for-profit company, we're mission-driven to see services improve for people that have high complex behavioral health needs.
Jesse, I've got a question about what experience you and Sam and some of you might have had with triage systems and crisis response centers.
Yeah. Sam, I'm going to pivot that question to you.
Sure. So lot of my career has been spent in, well, almost all of it has been in public mental health service. I was in Texas for over 35 years, and probably 25 of those years I was working at the state office, having to set up the policy framework for all kinds of services, including crisis services. And so while I've done some crisis work myself when I was doing clinical work, I have been focused on the system design aspects and the data. And then the consulting work that we've done, for instance, in Kent County, that was one where we convened all these stakeholders who wanted to have a crisis center, and we had to show them, well, you got to look at your whole system. It's not just building the center. And so through that process, spent a lot of time working through and learning from people on the ground, the ER docs, the people running crisis services, what it is they have to do. So I have not led a mobile crisis team myself, but I certainly know a lot of the issues that they're dealing with. And kind of where I come in is the ability to look at how do you take and put the policy and the structural framework in place to have the system be there and start improving itself through quality improvement.
Can you have people here in the community and to work with people? Or is this all going to be virtual? I'm wondering about how does this impact our police and fire? I mean, what use is it going to be for us? Maybe I'm simplifying this or oversimplifying it, but you see, what exactly can you contribute that will help our system from that standpoint?
Well, I would certainly hope that first responders would be at the table, because they're in the unfortunate situation right now of being frontline mental health crisis workers that they didn't really sign up for. And so they are the ones I've worked with closely. They have said, we don't want to be in this business. We don't mind helping. We want people who actually are trained in mental health to be up front. And that doesn't mean they don't want to sign up for CIT training, that kind of thing, and improve their competencies. It's just that they know that's not their primary mission. It's public safety or emergency medical work. So I think I've worked with a lot of those groups in the communities I've worked with to make sure that they're part of this solution, because they don't get to say no when they get called out. And so they need to be part of the discussion, and we would include them as a natural part of this. In fact, if you see our planning tool, that's one of the things we look at is the law enforcement piece of this and how many people are hitting the system that way, because often people are taken to jail when they don't need to be, when even the officer and the jail go, they really need treatment. I don't have an option, so we're gonna go ahead with this, and they penetrate into that criminal justice system when they really could be better treated out of there. So I think what we will be looking at will be a benefit to law enforcement and other first responders. Now, I'm not sure if I'm answering your question.
Yeah, what I'm looking at is what I'm looking at and referring to also, we want to focus on the usefulness of our triage system and experience that you may have had and how you can bring anything to help our triage system. We've kind of been beginning with it. Of course, we got backed up with COVID, but where we can implement that and fit it all within our regular system. And is this something that you've had any experience with? Is it more effective in the cities, metropolitan areas, et cetera? Or, how can it just fit in there and help us all?
And I might
one of the things that
Sam, I might just quickly add, the direct reference here is the triage center that is housed within behavioral health coordination that is under the department that I work in. And so we are looking at understanding triage's space within the crisis system here in McLean County. And so in some of the other communities that you've worked, have they had identified triage centers or crisis support centers? And what experience have you seen as far as their usefulness in the greater system of crisis management?
Uh, it's a good question, Vanessa. At this point, I will admit to not fully understanding what all your triage center does. But there are, there's things that have to be done in terms of evaluating people, deciding which route they need to go, whether it's for involuntary treatment or voluntary treatment, those kinds of options. So, what our group has been able to do, and I've certainly been out to the crisis centers. Some of these are the national exemplars around that, such as the Connections program out in Tucson and Phoenix. Now, those are bigger cities where they operate. The principles by which they operate are transferable. Exactly how they do it, maybe that's not exactly transferable, but we have access to those kinds of models to bring in and say, let's look at what are the issues you're dealing with, and let's look at how communities have solved that. And we can bring examples from a variety of places. And we work with a lot of folks who are doing this kind of work in other areas that we can call on as we need to get kind of case examples if that's what would be useful to the triage center.
It's not uncommon for us to reach out to other colleagues and people in our professional network to bring in subject matter experts when there's an area that we're not accustomed to. It goes along with our social work training and our principles and code of ethics of practicing where our competencies are. And so sometimes we find and work with programs that want to do new evidence-based programs that we're not trading fidelity for, and we'll consult with them, sometimes even bring them in a formal role to help inform a respective assessment.
Well, maybe you've just answered my question. I'm interested in the relationship with private practitioners in our community that are not a part of hospitals or big systems, but they have a caseload that they're carrying. Do you expect to engage with them, get any data from them? Is there a role that they'll play in any of this study?
Yeah, a lot. We oftentimes think of people with mental and behavioral health conditions in a quadrant model, and we think of people that have the highest needs as being served by a lot of the people that are encountering their mental health centers, their substance use centers. But for people that are private practitioners like myself that aren't connected with a larger system, this analysis doesn't look so much at connecting with them, but that's not to say that we couldn't look at that and look for avenues in which to garner their voice and their ability to connect with the system when they do have a client that's escalating in acuity, and especially during COVID where people were experiencing elevated depression and anxiety to a point that would move them into a level 3 or a level 4 need of care, that they know where to connect them to. Sam, do you have any thoughts on connecting or maybe even the first thing that comes to mind is public training or additional CEUs for helping practitioners in the field know, do we have competency of our system, right? Not just do I know what to do in a crisis, but do I know this system and getting this system out more broadly into the county?
Thank you. It's
I
my
think-
sense that they are players in this whole process, and to the extent that they feel engaged and want to be heard and give their input, would improve, the whole system, because sometimes that's the long ongoing system that supports families and people past the crisis point. And if we don't do that well, they're back to crisis.
Yeah.
Thank you.
Yeah.
Sam?
Just one comment on that. I think, and there's a community we're working with right now, and in Oklahoma, actually, Edmond, they've created a kind of a city municipal coalition, and it brought folks to the table. And one of the things they're developing right now through their strategic planning is a way to outreach to those providers so that they know what's available. Because I can tell you a lot of folks who do clinical work for what often gets referred to as mild and moderate mental health issues or mental health disorders. Um, they know that there's an emergency department. They don't know all the alternatives that a community develops because they're often not in a network that pays them to be involved in that kind of work, where the public mental health system does do that. So it does help to make them aware so that they can be available both to refer to the alternatives as well as receive people back that they know and have a relationship with, and to give them appropriate treatment and good continuity of care from one setting to the next. So yeah, that'd be great if they're willing to come to the table. We want their input.
Right, and I'll add in regards to the Edmond assessment and our work with Edmond is that we've had discussions, and I can speak for the children's side, we've had discussions with those children's providers about what are their barriers, what are they hearing from families, what are they hearing from youth in regards to accessing these services and supports, and when they need to refer a family to the crisis system, what is making it difficult for them to support that family in moving through the system in the way that meets their needs. So right, ensuring that dialogue is happening, and so that we're hearing from those private providers in the community as to what is available and is it readily accessible and is it meeting the needs of the families that they're serving.
I would just tag on to that conversation, primary care and pediatricians as well is definitely a group that would need some outreach and some discussion.
Jesse and Sam, we're going to have a lot of questions and a lot of asks here, I think, to see how things fit together. Let me give you one example. We have two universities here. There are a lot of people in that age, the 18 to 24 range too. How's this all fit together? How can we incorporate better our crisis system? How can we help so that we are actually helping the university people and vice versa? So those are just one example of things. We probably have a number of areas we want to target along with the crisis response questions. Okay.
John?
Yes.
Can I jump in back here?
Yes.
Hey, Kevin McCarthy. Just want to raise the lens of the camera up to about the 10,000 foot view and ask something probably, hopefully a little more simplistic from my level. But first, I just want to say I'm very excited about this opportunity and all the Tri-West folks. It's great this morning to hear your perspectives and the type of information you're looking for to start to give us a flavor of the scope. And to that end, I'm getting a sense of what the outcome of this process might be, but rather than me guessing, I'd like to hear from you guys if you could speak to, at the end of this process, what are we getting? What can we expect from perhaps what you've done in other systems and what happens after you're done with that information and that data? And then also, I've heard kind of structural component conversation. I've heard service level component conversation. As a part policy person, I'm wondering if you're looking at policy implications at a systems level, and are we getting recommendations on all of those things, or do your recommendations focus on certain pieces of this specifically?
Great. I'm going to forward to what next steps could look like for this planning tool. As far as the final, I mean, there's a list of like identify key informants and build out a timeline and request for information. We've talked about those things, but I think to your comment, what is the final deliverable? Well, we want to ask you all what's most helpful to you. Do you want a report? Do you want a brief? Do you want a presentation that really focuses and facilitates a discussion for next steps after? What did we learn? We're not tied to a particular medium. We want to know what works for you all and what takes whatever happens in the planning process, what we learn, how it can best be assimilated into what you're already doing and coming back to this plan. Sam, do you have any comments on what
Yeah,
has been most helpful for other communities that you've worked with?
yeah, I'm going to just step back a little and say that unlike a lot of the communities we go into, and a lot of our work is county based. Not all. The Edmond project is specifically one city within a bigger county, but a lot of times it is county based, like Kent County, for example, in Michigan. So it was Grand Rapids, but the outlying areas also. The one thing that you all have going for you that, and you may or may not realize this, but you are somewhat unique in that you already have this body of people coming together that have been doing this for a while, that have really been focusing on behavioral health issues in the county. So you're a step ahead of many that we go in and work with. And so that was one of the things that excited us about this endeavor. So what I think when we go in and do these assessments, these are very big projects when we do that. And this one will be a narrower in scope around that. But we think what we can do from what we've learned, we created a planning tool based on what we were learning. And we thought this helps us organize things. And we're hoping it will help you see things through the lens of this is your current system. And these are kind of critical data points that you would want to monitor and track to make sure your system is moving in the direction you want it to go. And if it's not, what you might be able to do to fix that or to make adjustments to that. So if law enforcement says, I am doing too many protective orders over here, I want to reduce that. Well, we can look at that and why is that? So it's really kind of a systems assessment of how you've engineered your system so far. And then what we can do with the tool is say, let's think about how your desired state, where do you want to be, and what is it you're going to have to change to get the system to perform differently. So I'm thinking we're going to narrow our scope into that realm to give you a picture of those things so that you would know what you have to do. You know, after we're long gone, you would still know these are the issues that we and the controls and the levers we have to make the change to go to the desired state. And those things are really uniquely local. And we can learn from other areas and bring that information to you, but some of it is you figuring out what's going to be different. And that could be a simple, not simple, but there could be a piece around looking at how are incoming crisis calls handled now. And I think you have the benefit of a call center that's must be pretty good if the state hired them to take over all of the state's call center operation. But how is that coordinated with 911 calls back and forth? And what protocols do you have in place to deploy law enforcement or EMS or mental health or some combination of those? Is that really thought through in a system sense so that everyone who is involved in that knows what the protocol is? That's a system. You know, one person figuring that out as they go isn't a system. It's everyone understanding kind of what are the rules of play here and how do we move this that way? And then what data do we have to know that it's working? And I think we'll be able to sharpen the focus on that and build on work you're already doing. And one thing we look at is what capacity do you have? And often in doing this work, it shows everyone at the table, including us, what you don't have that you really need in the way of information and data. Because often that's one of the most important things you can do is go, we need to start tracking this. It's an uncontrolled variable because no one is tracking it, and yet it's having a big impact on our crisis system. And I think we can shed some light on some of those and then work with you to come up with the best solutions. We can provide alternatives, but it's up to you to decide which ones really work for you.
Susan?
Yeah, I have a couple of things. One, in the update, in the mental health action plan update, we have quite a few recommendations for the crisis system already. So how does that play in what we've already decided from our, the update and talking with law enforcement and first responders and things like that and the data that we have in there? How does that play into what you're doing? Because to me, a lot of that's duplication of what we already know we need. So I guess, is it going to be just an expansion or more a deeper dive into that or what? So that's my
Yeah.
first question.
Yeah. So again, I read an earlier iteration of this, and you do have some volume data in there, but it's not complete for the entire system the way that we use it. And so again, we're not going to come in and say contradict. We're going to say here's what we've seen by taking another dip, and allow you all to determine, does this really move us to anything? It may further validate, yeah, what we put in here is right, and it's going to help refine it a little bit more. And yes, and to what we've already done. You may get a better picture and you say, hey, we want to tweak something. We see something right here and we just want to refine it a little bit further. And so that's how we view this assessment activity.
Okay. And then the other thing is, and maybe Judge Foley can help me on this one, is I think that maybe we need to talk with CJCC on some of the data that they have, because they're the ones that can get some other data. So I think maybe talk to Judge Feldheimer to kind of give him a heads up, if you wouldn't mind.
I just want to add another thing is we don't work in a black box. And so once we get started, we're not just like working away and then we poof. If you end up being dramatically surprised at the end, we've done something wrong. And we're doing this in collaboration with you. And as we learn something, you learn something. And so by the end of the product, hopefully it's a little bit boring at the end because you already have seen where it's been going along the way.
Okay, Diane?
I think I want to go back a little bit, Kevin, to what you were talking about in terms of the outcomes. And I know this is beyond the scope of your work, but I am sure when you're looking at the systems that part of what you will see is the lack of state resources or regional resources, especially for acute care, that is creating first responder issues, that is creating, and I've said many times, I'm so proud to be in McLean County and the work that we've done, but the issue is for fuller resolution is bigger than McLean County. So I would just say everyone that is in a position of government, leadership, politically active, needs to be paying attention to the initiative that the governor has started around transforming mental health and behavioral health services for children and youth. And I know we all get weary of yet one more state work group and one more state task force that maybe comes out with recommendations that don't get implemented or don't get funded. But it is critical. Our EDs are locked up. Our crisis response is bogged down because there is no available resource to plug in to stabilize these kids and families after you've had the brief stabilization of crisis. And it's because they are all backed up in psychiatric beds, inpatient, intensive outpatient programs. So this statewide process that's just getting started, I really encourage all of you to pay attention to it, read about it, and make your political voices known in that process. It's going to be pretty critical to the work we're doing in our county.
And we hope that whatever is discovered through here becomes leverage, information in hand to take beyond McLean County and make compelling cases for those resources.
And I think it will have to be, back and forth communication, right? So there may be something that comes out of this that we can use to advocate, but knowing and paying attention to what is happening at that state level may also inform this process as well, because there are, of course, things that providers have to do because the state has said so.
Okay. Anything else, Sam or Lisa?
Yeah.
Okay, Jesse, thank you very much. Okay. Joan, I'm sorry, I didn't see you.
I just wanted to make one final comment on behalf of Jesse and his team. And because in the past, when I was at Chestnut, we worked with the state. We had a state project that Jesse and his team were the evaluators for. So we didn't employ them. The state did. They came in and they worked with us. And they were so helpful to us to create change in our own processes without making us feel like we should have been better, or we should get this already or whatever. And we never felt like they went back to the state and said, oh my God, those guys, kind of thing. And so I just wanted you guys to know that having worked with them in the past, I found it to be very beneficial. And actually, when I was at Chestnut, recommended this project. And I still recommend it in my new role at the center, and feel like it's very important for us as a system that does crisis, for us to really figure out where can we do it better? Where can we collaborate better? And I don't feel like, knowing my history with Chestnut, I don't feel like any of the information is going to be utilized by Chestnut in any way other than for them to make their programs better and to make them better partners with the rest of us too. So I just wanted to put my 2 cents in there. So
Thank you, Joan.
Jesse, you can pay me later.
I should have started with that. Yes.
I appreciate the people that have come to hear this today. These are people that are on the front line of seeing our patients in their most vulnerable, most difficult times. And having them here, being interested, having a voice in this process is really good. So thank you for coming today. Appreciate all of you.
Yeah. Thank you for that. And to tie these two comments together, it goes back to when we started. We want to see McLean County succeed. We want the BHCC to succeed. That means people are getting help. And when we go around and talk with stakeholders, we want them to succeed too. We want law enforcement. We want the criminal justice systems to succeed in helping people get better. We're not auditors. We're not investigators trying to figure out who's the problem here. We know, and we take our assumption is everybody's doing their best already, given what information that they have, what controls that they have. And so we want to say, how can we help you characterize what's happening in your space to help the larger system? And so we take pride in how we work with stakeholders. And if we move forward, we see ourselves as ambassadors for you all. And so we want to make sure that everybody sees that our interactions are reflective of how you all view them and see how important they are in the community.
Thanks, Jess. Thank you.
Oh, McLean. What did I? McLean. Oh.
Everybody does.
Yeah.
Okay, thank you very much. I've got just a few other things we want to look at. We're running a little bit late. I want to congratulate everybody for what we've done so far. It's been kind of a long period of time since we started BHCC, and I just want to make a few comments on appreciate the commitment to the community and to our mental health areas. Still got a lot of work to do, unfortunately. As you can see, I think Monday's meeting will be very important for some of you as you're working through some of these projects. Much of what we've done has had dollar signs assigned to it. Some of it we haven't spent, as you've probably heard recently, but much of it does not. In fact, if you look through back at our mental health action plan and the one you just saw, the revision of 54 recommendations were made in it. Overall, 13 or 14 of them had monetary components to it. I'd like to just focus on the old 2015 plan because I think it's very similar to what we have here. So if you could put up slide 1 and 2. You've seen these before. Just use them for a minute. Just read down through them as kind of a checklist of things that came about even back in 2015. What have we been able to accomplish? What haven't not we been able to accomplish? There can be no turf issues, a silo approach. We talked about that many times, about the needs of collaboration, need to speak freely, openly, and honestly. I think we've accomplished certain things there and certain things we haven't accomplished. So how much have we? Where are we? Information sharing, absolutely. Coming together, absolutely. Interchange of ideas and interacting with each other, different concepts, different philosophies, yes. Key word I still have in my mind, and have been frustrated over the years, has been implementation. We've got to get some things coming together one way or not. And maybe these people from Tri-West can help us with some of this, but I still think it means coming to the table. Where are we? What can we get done? Why can we not get some things done? What's it going to take? We've got the money, and maybe we'll have more money with some more grants. We're working towards that. You know, back in 2015, and this is coming from a tired guy maybe, but the county stuck its neck out. You know, we're hearing compliments about, oh, these people come in and they say how far ahead we are with some. But really, hundreds of hours have been put together from many of you, what you've done and what we've tried to do as well to get to where we are. But what's this all about? Are we going to get some more things accomplished to help the people? Is it money? We're helping people. Is it money? I don't know. We've got to figure out ways to collaborate, and some people are going to have to take it upon their organizations to take some things on their shoulders and move it forward. Right or wrong, mistakes or not mistakes, I know you all have to be conscious of what you're doing physically with your own organizations. But any way we can find to work together is why I think we're here and what we can do. So hopefully we're going back again. I'm going to ask people to still commit. Let's get back to our original mission. I don't know how much different has really been done since that time. I think we've got a couple other slides, or one other slide to put up real quick on it, just for you to reflect upon. We talked about in there the committee structure. We talked about kind of the system. Where does everybody fit in, including the Board of Health, including 377 for developmental disabilities, including the county administration, which I'm trying to represent, and Mrs. Schaefer's represented as well. Just stop for a minute and just think about some of the things. Where are we? There's many pieces that have to be put together, and nothing else we've accomplished that coming together, but we need to get some implementation done. Recently, we've been kind of called on the carpet as representatives for everybody here, as for the county, as part of our sales tax initiative, and we need to do some more with it, and we need to put it together. It can't get done without somebody stepping forward and being willing to collaborate in one way or another. County took on more maybe we needed to at one time, because we felt like, though, the need was there. There were things that we wanted to at least get started and get going. We're moving forward in some areas. To me, youth is very important. And any way we can find to help all ages and all levels of youth. That's why I've even mentioned university here, that we can do any help, I think is very important too. Intensive outpatient kind of came and went. Can we revisit it? Were there some things we can do? Maybe some things we can put back together from that area. ROEs come in and put it together, a nice parallel system for what they've got with their alternative school to help those in need. But that's education and students, and that's one particular part of it, but that's not everybody. And it's not all levels. And then we can even, and when we talk, we always talk about prevention. Absolutely, it's there. We know it's there. But we've got to figure out what we can do and divvy up this pot and at least get going. Let's get going and let's commit and see what we can get done. And I know that means answering questions like personnel, who can carry these things out? What have I got to work with? How can we help? So that's all I've got. We may be asking you to get down in one thing we didn't accomplish very well over these last 5 or 6 or 7 years was work groups. Maybe we needed more. Maybe we had small groups. Maybe in the revision effort that Mrs. Schaefer did, she called some groups together. We had initiative. One time we had voluntary work groups. I can remember being out Babyfold talking about housing. And I remember being over Path talking about crisis. Some things came out of our original plan. Maybe more than we realized. At least our community came together. I sat in this room with 72 different leaders identifying needs at one time. And Susan was with me. So let's take a minute. Maybe this revised plan, if nothing else, was to take a moment to reassess status report, reassess our interrelations between different organizations. How can we do some things? Get together. So that's done. I'm done talking. I'm done coaching. I'm done preaching. Thank you, Jesse, for coming. Anybody else have any comments for the meeting today? This was an extra meeting that we had. I appreciate you taking the extra time and effort to come in. We'll get back to you soon. I want to thank Vanessa for all she's done and Cassie for all that she's done to help us as well. Stephanie?
John, do we want to tell the group about the current SAMHSA SOC grant work that's being done?
I will let you do that if you'd like. I didn't know how far we wanted to go with that. I just said there's a meeting Monday.
There is that.
Hoping that you are all involved in the meeting or understanding what I was talking about.
So several members of our council stepped forth and expressed interest in pursuing a system of care grant, a SAMHSA grant for child and adolescent youth. And so we have began that work. There are many people here around this table who have stepped up and stepped into this process. Following Monday, we will have a clear direction of where we are going with this grant. And so at our next BHCC meeting, you should expect to have a full report of where we're going, what we're focused on, and how we feel about what we've been able to put together.
Thank you. And to be fair, the reason why I suggested that we kind of just share that news is to tag on something you said, John, about the services for children and youth being so important and needing to move forward. And one of my hopes is out of this planning for the grant process, if we don't get this grant, we have something we can use to then potentially look at what can we do here, even without that grant.
I've been asked questions by why aren't you spending money? And it's kind of hard to answer that question. We say, well, we got to get everybody together so we can do that, And that's kind of a situation we're not usually in. And because the county doesn't operate that way, that. We try to be fiscally responsible of what we're doing. And there's things like money of last resort and those things, that kind of resonates with some of us more than it does other people. They don't even know what we're talking about sometimes. And so that is an issue, so we want to maybe do a better job with outreach and getting information out and promote better understanding too, but we've got to just move forward. That was my whole point. Thank you. I have nothing else. Anybody else? Well, we are adjourned. Thank you for your patience and staying. Chiefs, coming. I hope we can get you some more help and provide information. Eric, thanks. Aaron, thank you.